Hi everyone. Sorry for my late arrival. We had a bit of a link snafu, but I can see that the discussion is already underway. So, I hardly need to be here, really. I can be a spectral presence. But it's really lovely to meet you all, and thank you very much for making me welcome. I guess we'll get started. Just before we start the formal part of the meetup, I thought I'd just double check I'm essentially going to run this as a kind of panel discussion, so I don't have a substantive presentation of my own. Just for ease of dialogue, are we okay with raising our hand via the Zoom screen when you want to interject, just so that I can make sure that we're having a kind of seamless discussion? Can everyone see the little raised hand at the bottom?
Yeah.
Sounds good. Okay, well, and I think we'll aim to go for about 45 minutes, but we've got a little bit of slack in the system, certainly not past the hour. But thank you all very much for making the time. And as you know, I think I'm Sally Davies, the Deputy Editor of Aeon magazine, which is a popular magazine of science, culture and philosophy. And it's a real pleasure for me to be here today. So at this meetup, we've obviously gathered together yourselves as distinguished Brosher Fellows and former chairs of the meetup to canvass various visions for a post-pandemic world. And many of you will have seen, I think, grim figures just released in the last 24 hours that indicate that the global death toll from COVID-19 and its variants has now reached 4 million people. States are, of course, racing to vaccinate their populations, but many are doing so unevenly, which not only places those who are already underprivileged and marginalised at greater risk, but also has spillover effects for everybody in terms of creating wells of transmission that breed new and potentially vaccine-eluding strains. So against this sobering backdrop, I thought today we could probe the ethical, political, and epidemiological dimensions of what it means to quote unquote end the pandemic, scare quotes very much intended there. So it seems unlikely that the world will or indeed should go back to the way it was, but instead I thought we might reflect on what new pathways are opening out before us, what risks lie ahead, of course, and without wishing to sound Panglossian, what potential opportunities we might now be in a position to embrace in terms of reshaping relations between citizens and states, given what we've been through. Of course, posing the question like that makes it sound like COVID has been some sort of monolithic shared trauma, when in fact any one person's navigation of the pandemic has been fractured according to individual risk factors, preferences, economic privileges, communities one inhabits, and the national regimes in which we are all embedded. So across this spectrum of experience, I thought we might try to tease out some scenarios for what the post-pandemic world might look like. So perhaps before we begin the discussion in earnest, I'll just ask each of you to go around and just briefly introduce yourselves so that our audience has some sense of who's present. No need to raise your hand for this. Perhaps I'll start with you, Arthur, if I may.
Hi, it's Art Kaplan, and I'm at NYU Medical School, where I run the Division of Medical Ethics.
Fantastic. And I'll just go through as I see people appearing on my screen. Bertrand?
I'm Bertrand Tate. I'm a professor of cultural history and a director of the Humanitarian and Conflict Response Institute in Manchester. And I'm a historian of medicine.
Thank you. Laurie?
I'm Laurie Zoloff. I teach at the University of Chicago, where I'm professor of religion and ethics and senior advisor to the provost on programs in social ethics.
Thank you so much. And Ruth?
Yes, I'm a professor emerita at Albert Einstein College of Medicine, which is in the Bronx, New York, but I currently live in Pittsburgh, Pennsylvania, and everything is done virtually.
Thank you. And Deanne, I think you're last on my screen.
So I'm Diane Paul. I'm professor emerita at University of Massachusetts, Boston. I'm a historian of science and medicine, specializing in genetics. I do what's sometimes called policy-oriented history.
Thank you so much. Well, look, let's just kick off with, I think, what is quite a broad question, but what do we feel is the meaning of what would it mean for the COVID pandemic to end? I mean, I guess in asking that question, what I'm trying to get at is the extent to which an answer is an epidemiological answer and the extent to which it's a political answer about the level of risk that different societies are willing to tolerate, and crucially, who is going to be expected to bear that risk. Would anybody like to jump in there? Bertrand, did I see you raise a hand? Sorry,
Yes.
I think by raising a hand, I meant if we could.
Sorry, yes, I've identified the right button. I mean, I just think if we put in perspective, historical perspective, when do pandemics end? Is a much harder question to answer than when they begin, and most pandemics roll on for decades. And if you think about the cholera pandemic, so the notion that a pandemic may end in a matter of months or even years is perhaps partly the problem, the way we're actually framing the epidemiologically, but also how we think about endings. We're much better at knowing beginnings and endings, and there's a lot of research now done on the history of, I don't know, the aftermath of wars, and for example, which is often extremely long and painful and slow and multi-generational sometimes. So I think asking the question of when the pandemic will end is probably going to be incredibly complex.
It's really interesting you say that, because I mean, it seems to me that something that has struck me throughout the pandemic is the attention that the pandemic has thrown on this question of kind of temporality, that we live at a moment where sort of different temporal regimes seem to be colliding. Kind of on the one hand, this notion that you could be an incubator for a disease that only manifests in a matter of days, and sort of having to inhabit that space of uncertainty about unfoldings, the temporality of exponential growth being something that humans find very difficult to get our heads around. And on the other hand, you've got this sort of thick temporality of the historical and structural forces that have kind of led to this point where COVID becomes a crisis. Of course, the state of our healthcare systems, racial and economic inequalities that affect how the disease moves through society. So it does seem to me that there's this very interesting question of the role that our conception of time has played in how we manage the pandemic. And I wonder, I guess that raises the question, will new conceptions or will new relationships to the question of time emerge from this experience in different societies, do we think? Oh, yes, sorry, go ahead, Laurie. I'm still getting my head around seeing little hands in the corner of the screen.
Right. So, I'm thinking of the when you spoke, Petrana, of the book, Fabian's book, 83, Time and the Other, a book about anthropology, and it's about how we think of ourselves as in modernity, and anthropologists look at other societies as primitive, or as if the time hasn't happened to them, that the Middle Ages, was our Middle Ages and not their Middle Ages, and this notion of simultaneous times, very much a part of our scholarship and humanities. So, but that's really what's striking to me about the pandemic. Two reactions to what you said, Bertrand. One is that we can end epidemics. We ended polio, we ended smallpox when people decided it was enough and spent enough money to do it. Not malaria, right? We ended malaria only in our time in the Northern Hemisphere, not in the global South, and it's essentially a financial decision. The same thing, of course, could happen to COVID, and in my city, in Chicago, where the story of COVID is the story of race, class. It is the falling back into place of the pieces of our city has fallen back into exactly the same patterns as existed before the pandemic, where despite enormous efforts to immunize African Americans in the South Side, where I live, still the rates of vaccinations are dramatically different in Black and white communities, and cutting across the same wealth lines and cutting across the same class lines and race lines as always happens in the city of Chicago. Same map can be used for violence, can be used for death, can be used for diabetes, can be used for COVID. And that is really striking to me, that we could in fact emerge into a society where some of the people are watching the World Cup or Euro Cup, sorry, congratulations, England. And some of the people are dying in hospitals even now. So that difference puts into relief something that we know as bioethicists is true about many diseases, but we've been able to ignore because they're not perceived as an immediate threat. And so we now enter into this next phase where some people can be vaccinated and some people have not been.
It's interesting what you say, because it seems to me moments, I mean, looking at this from a very synoptic perspective, but moments of generational rupture like this actually provide openings in which economic and social relations can be fundamentally reimagined, inequality can be addressed, or they can also provide an entrenchment of existing inequalities. And that kind of ambivalence or the potential for these different pathways is something I'd like to pick up. But Ruth, I'm conscious you've had your hand up there, and so let's go to you. You wanted to jump in here.
Yes, well, I was going to answer the very beginning of the question, one of which is to say that there are scientific questions that are still unknown. How long will the vaccine remain protective, and will new variants that are inevitable, not only the strong ones that are available, that are around now, like the Delta variant, but others that the vaccines might not be effective against? So those are unknowns about the scientific aspects. We already know that there are elements in every population that either will defy the protections that we've been told really work. This is certainly true in the United States. And there are other populations, very large populations, such as in India, where crowding, poverty, and all of the other factors that lead to the spread, or that have led to the spread and will continue to do so, can't be controlled. So I'm just going to say I am somewhat pessimistic, given the scientific unknowns and the catch-up that'll be needed, because obviously new vaccines will be required, more studies of vaccines, more people who are willing to engage in, to be research participants for vaccines. And I just see this as continuing. But I'm sorry to be pessimistic, but that's my take on the question.
I mean, it seems that there's this sort of ratchet effect where we have to accept a degree, there's always going to be a sufficient degree of transmission such that there's going to be a new variant, such there's going to be a new vaccine, but that vaccine won't catch up in time to prevent a new variant. There was perhaps a window of time where we could have prevented that sort of ratcheting effect, but it seems that horse has bolted. So Art, I'll let you, oh, sorry, Ruth, did you want to jump in there? Or Laurie, sorry.
It's also unclear that how many times you can get an RNA vaccine. That's an unknown factor as well, scientifically unknown. Mm-hmm. It's not clear you can get it more than once or twice. So constantly getting the vaccination with the mRNA, not necessarily clinically possible.
Right, interesting. Art, I'm conscious you wanted to jump in there.
Yeah, I was going to say, it seems to me very clear that pandemics end politically. Half of the United States, for example, has already ended. Politicians are saying it's over, everybody can go back to normal. Britain is doing something like this in the middle of epidemiological evidence to the contrary, but they're sort of, play soccer or football and everybody out and so forth. So I don't think epidemiology drives the declaration of an ending. It's pretty much a political statement. There's also some nationalism involved because people are quite willing to say it's over here, even if half the world is dying of COVID still. So I think in that sense, the ethics has to be sensitive to what the politics is. And in some ways, responding with epidemiological proof that it isn't over, evidence like that, doesn't necessarily engage the declaration of I'm sick of this and we're going back to school and I don't care and the economy's got to perk up and da-da-da-da. You got to kind of meet that, I think, head on if you're going to argue about the need not to let our guard down. But I did want to point out that in some large portions of the world, it's either been declared over or Japan is lurching into the Olympics with a state of emergency in hand, but there we go. So that looks pretty political to me.
It seems it's certainly been met. I mean, I'm based in London and in the UK, there's this sort of simultaneous sigh of, oh, thank goodness that these restrictions are lifting on the one hand, but then from other corners they're saying, but hang on, we don't feel safe going out in public yet. I'm not comfortable about the fact people are allowed to take their masks off, and trying to reconcile the different human goods that both of them are understandable responses in different ways. It's very challenging, and I guess it's this balance that governments have to strike between the extent to which the pandemic becomes a question of collective responsibility, and at what point in the pandemic or after the pandemic do you return some degree of individual autonomy. But of course, the pandemic reveals that individual autonomy is circumscribed by structural factors, and that individual choices have structural implications. So it's very difficult. Bertrand, I'm conscious you've had your hand up for quite a while now.
No. It's I just wanted to pick up on, but we can rebound on several conversations here. But Laurie made a point about in reference to smallpox. Now, it's worth remembering smallpox once was a pandemic when Europeans brought it to the Americas. Interestingly, then becomes endemic in most places, but retained an epidemic quality which was weaponized in some contexts, notably in the American, in relation to American native people in both North America and South America. So it's kind of interesting, because if you think that, and one of the commenters in the chat pointed out, we are moving towards an endemic stage. It doesn't mean that it will stop being an epidemic by being endemic, and it doesn't mean that it won't be weaponized in some way through social forms of violence. And one example, I think, of this taking place, and Artin makes a really good reference, and I'm very much with Ruth in terms of pessimism, is the reopening of the United Kingdom right now, which is essentially a form of violence against the young, who haven't been included in the process of vaccination early on. We are going to be exposed to something that we don't fully understand, which we call long COVID, for want of a better word, on a massive scale. We know it's going to happen, and that's even without touching on the fact that the health system may not be able to cope with a sudden surge in the coming weeks that we can already prefigure, because it's happening on a daily basis. So it's very interesting that we are looking at, by saying, okay, the disease is now endemic, or we are past the epidemic stage or the pandemic stage. It doesn't mean that the violence that is actually filtered through, and the forms of social inequalities and violence are going to be diminished by it. Far from it, they're just going to become less visible, and certainly less of a political battleground. But I think it's fascinating how the United Kingdom is presenting as a liberation the willful sacrifice of an entire generation. And I don't mean that in dramatic terms, but we have to think about what are going to be the consequences of reopening in the middle of a surge. And that's going to be fascinating for historians of the future, but traumatizing for an entire generation, because there is a form of political violence at play here.
I think, it's certainly a gamble, and I think even those who defend the policy would admit as much. Here, the discourse among those who are in favour of reopening is very much it comes back to this question of temporality. One of the arguments given for the reopening is to say, well, if we defer the reopening for several months, all we risk is pushing back the peak to the winter, when the hospital system will already be under strain, and in fact arguably will be under more strain than typically, because there is this immunity debt in the population from
Sally,
lockdown. I'm not saying I agree with this, but
the data of the NHS right now is that they are living the equivalent of a winter crisis in summer. And so if you actually ask people working in A&E services in the NHS system, the system is already at very much an alarm level. So it isn't. The argument is a political argument. It makes sense. Summer is easier than winter. People are outside. They're not. But the reality is not there. It's actually a debate. It's entirely political. It's not a debate grounded in actual epidemiological facts.
Deanne, I'm conscious you've been quiet during this conversation. Do you want to come in here on any points?
Well, I was just reading, first of all, as you know, I'm the one person on the panel who has no expertise, scholarly expertise in relation to COVID. I did have severe COVID. But I've been reading through the chats, and someone, there's no name, just says to all panelists and attendees, that I am pessimistic if lessons will in fact be learned. And that has prompted a thought, because historians, which I am, are always interested in lessons of history and whether there are lessons of history. So when I have been thinking about that. So if I can make a point about that, although it doesn't directly relate to what others have been discussing.
By all means, I think it's,
or I can wait.
I think it hooks in well enough, and I think that the conversation's capacious enough to allow generative tangents. So please, by all means.
Okay. So I think it's extraordinarily difficult to draw lessons from history. And at the very first brochure meetup, Joanna Liu, who had been, I think, the president of Doctors Without Borders, gave what I thought was a very, very interesting art presentation, in which she noted that, first of all, everything that we thought we knew basically turned out to be wrong. So that if you looked at the epidemic preparedness index, the US was number one. And all the countries that were at the top or near the top ended up at the bottom. And I think the same is true for the beginning of the pandemic. Many historians were asked what lessons they would draw from the pandemics of the past to guide actions now. And they tended to say things like travel bans are counterproductive. Quarantine does more harm than good. David Jones, who's a very well-respected historian of medicine, wrote a widely circulated piece in the New England Journal of Medicine, in which he, let's see if I can actually just find them. History suggests that we are actually at much greater risk of exaggerated fears and misplaced priorities. There are many historical examples of panic about epidemics that never materialized. For example, H1N1 influenza in 1976, 2006, and 2009. I don't say this by any means to criticize David. It was exactly my own view at the time. But it is an indication of the fact that the lessons that were drawn from past epidemics meant to guide us now, on the whole, were ones that, on the whole, ones that now seem misguided. And how, in more generally, as Joanna Liu suggested, we ended up doing sort of the opposite of what scholars would have in respect to quarantine, in respect to travel bans, and so forth, had been thought to be best practice. So I think it's remarkably hard to, if we ask, well, what do we learn from this that's useful in terms of guidance? Yeah, I don't know. The problem is that it's always possible to draw many different lessons from history, and for any large historical event, and knowing which of those lessons is the right one. Well, as Hegel said, you don't really know till it's all over.
It's interesting too, because even had we, well, I mean, what I hear you to be saying in some sense is that even when we do try to draw lessons from history, we don't necessarily take the lessons we should. I mean, as part of the UK's pandemic preparedness strategy prior to COVID, there was an assumption that essentially there would be political tolerance there would be a greater degree of political tolerance for excess deaths. And moreover, that there was huge surprise among political elites here about the extent to which there was compliance with lockdowns, because the pandemic preparedness strategy presumed people would not comply with lockdowns. So, I mean, I think that also there's there was the expectations about how people would respond to this unknown risk were kind of confounded. It's unclear to what extent a more probing and sensitive analysis of history would have allowed us to foresee those things, and to what extent they're just intrinsically unforeseeable. Bertrand, you want to jump in?
Just to jump on to echo Diane's point, I think it's very striking, and one of the comments made that, why haven't we learned from the great Spanish influenza epidemic, so-called Spanish influenza epidemic? And I think part of the problem is that we did learn from the great Spanish influenza epidemic, but this may have been the wrong epidemic to learn from, and that's part of the issue. And interestingly, the Spanish influenza, most of the historical scholarship is less than 20 years old. So it's very striking that in the 80 preceding years, people did not regard it as a momentous an epidemic or pandemic as we now recognize it to be, or they acknowledged it, but they acknowledged it as part and parcel of the aftermath of the First World War, and the globalization of the World War. So we're looking at Spanish influenza or flu epidemics of the past as the relevant template. But it's not clear at all to me that it is a relevant template, and there may well be other diseases that we may have to consider as part of our historical perspective. I mean, for example, the way we treated tuberculosis prior to antibiotics, the way we treated notifiable diseases in the 19th century, like scarlet fever, and maybe more relevant because in a way some of the mechanisms that we are currently applying resemble more those mechanisms of the 19th century. All of them contain a degree of violence. Notifiable diseases, for example, discriminated against the poor. The way the notification took place was very class-based and very much targeted migrant people and gypsies and Romas, and any group that was regarded as propagating disease was segregated as a result. So there's all sorts of politics in the past that are kind of interesting. I think, are good alarm bells for us when we actually see the deployment of all sorts of social engineering today. And but whether these are lessons from history is a different matter altogether. I think there are many fundamental ethical questions that were raised then that should be raised today.
It's actually, hearing you speak, I mean, I'm reminded of the theorist Rob Nixon's idea of slow violence. And, what I hear you to be saying in some sense is that, I mean, in the context of his work, he's talking about environmental collapse and slowly unfolding environmental disasters that wreak forms of violence upon vulnerable populations, but they can be structurally channeled by political leaders. And it seems to me that what you're saying, Bertrand, is that the unfolding of the pandemic and the decisions being taken around ending the pandemic, or living with the pandemic, as we should perhaps call it, is arguably a form of slow violence that's being inflicted upon populations. Laurie, you want to jump in there?
Well, this was exactly what I was saying. I get very, I think it's very disturbing when people talk about living with the pandemic, or it's going to be an endemic disease, because they never mean themselves. They never mean I'm willing to die. You know, my family, I'm willing to. You know, what they mean is other people, poor people, people who don't count morally to us, or more profoundly economically to us. That we could, and that let's make COVID just like flu, which is a disaster, actually, when you think of it, because flu killing the vulnerable. I don't want to live in a society where some huge proportion of people every winter just die because we don't really attend to them or care about them. So this notion of what the key thing as being the economy going forward, that the engine of the economy had to go forward, was the defining choice that was made in country after country. And it's not only political, as Art pointed out, it's also economic, because your economic choices about how much we could stand, how much the stress tests on the economy could bear. And in the way that half of the United States really rejected the science as a paradigm, I really think they rejected the moral possibility that one was obligated to care for the other. One had to live as if the stranger mattered. And this accepting of endemic relationships is a denial of that essential reality that the other is yourself, and that one's self-love has to extend to the other. So it's a profound philosophical error, an ethical error, to accept that language of endemic reality. And I think we have to continually say that and continually fight against it. I share Ruth's pessimism and the pessimism of the panel. I think we're not over yet, keeping my masks at hand, because I think it's that narcissistic attention to one's self at the expense of others that is the philosophic choice that's been made by country after country. So economically, politically, but also philosophically, making the choice for the self over the other has been one of the bedeviling aspects of this that we have to, as bioethicists, attend to.
I think sorry, I didn't mean
that's our responsibility. That piece of it is our responsibility, to constantly reject that notion that we can live with it because it means the death of the other, and it is exactly Bertrand's violence. The status quo is violence.
And I think what's a real shame about this is that there's a kind of missed opportunity here, where it seems to me that COVID sort of broke open certain invisible power dynamics. For example, it rendered the artificial distinction between economic reproduction and social reproduction very visible. All of a sudden, family life and entanglements of caring for children and caring for the elderly, which as a good little employee in late capitalism, you were to religiously keep away from the eye of your employer. All of a sudden, those became legitimate subjects of discussion that should affect your productivity. So in a way, that seems like a really exciting thing to happen. And it seems like there's this moment to like really reconsider ethics of care towards one another. But what I hear you to be saying, Laurie, is that there's as a counterpoint to that, there's this kind of doubling down on this discourse of radical autonomy, of the protection of some kind of implicitly white Western sovereign self, and partitioning sort of certain populations into some box where, to use Judith Butler's words, their lives are no longer grievable. They're no longer kind of considered full subjects of human concern. So yeah, it's kind of this moment where there's this tantalizing possibility of a new ethics opening up, but many of us seem to think that as a whole, Western liberal democracies have rejected that possibility and have instead pursued radical individualism, essentially, at the expense of it. Diane.
Sorry, I tried doing that.
Oh, yes, I'm sorry, I was on my tangent of my own. I was about to bring you in. Please go ahead.
So Laurie's comment, I think, relates directly to an article that Barry suggested we read on moral distancing from the pandemic.
Mm-hmm.
And I wondered if he or somebody else would like to discuss that. I thought it was fascinating. I wasn't sure that the solution of backward contact tracing was plausible, but I thought the analysis was very, very interesting, and it's directly relevant to the comments you just made.
Actually, maybe this would be a nice moment, Barry, since you've joined late in the day, just to briefly introduce yourself. And please do. This sounds like a very interesting line of discussion if you're happy to.
My apologies. I had to go to a
Not at
doctor's office, wear a mask, and feel the slight changes in rigor in the medical establishment as they reduced some of the protocols.
Nope.
The promise of the vaccine was evident. So I'm Barry Furrow. I'm a professor of law at Drexel University, and not really an epidemiologist, but it struck me, this particular article that just popped up in one of my many resource messaging emails I get. It was interesting, and I thought the backward-looking tracing doesn't sound like it would ever work in the U.S. Might be great in Taiwan, Singapore, the Asian countries that are good at this anyway. But the way of thinking about, and really not quite excusing, but looking into the mind of people in South Dakota who don't seem to want to get vaccinated. And why don't they care about everybody around them? Well, they don't see people getting sick. It's a very underpopulated state. I was born in South Dakota. I had my first polio vaccine in a cup when I was 5. Everybody standing in line, and so grateful. Polio, because people had polio around us. They wore leg braces. We were highly aware of polio. And so the South Dakota of today, which is Republican, I'm not sure that explains it all. They just don't feel the risk directly. And I think this article is giving some reasons to think about how you deal with that attitude and moral distancing, because you don't have a sense of the risk within your perimeter. That's an interesting point. I agree the solution is a little bit unlikely for us, but it's sort of trying to develop some empathy for the people who are anti-vaccine, which is hard for most of us to do. We don't get it. So it's a kind of a starting point, I think, for bioethics, and kind of a principle of empathy. How do you develop empathy as you look for tools to move these people, whether you $1 million lottery, whatever it is. I'm not sure all these economic tools are the answer, but it's a starting point.
Ruth, you want to come in here?
Well, I just wanted to bring up something that hasn't yet been mentioned, but another contentious point, and that is vaccine mandates or vaccine passports or certificates, as they're called. There are some people in the scientific community who have been urging very strongly, and you can see this in letters to the editor to the New York Times, for example, urging that there be that governments issue mandates for various segments of the population, that employers mandate that their employees become vaccinated. And then there are all of the versions of vaccine passports that are now becoming evident. Israel as a country was the first to develop a vaccine passport, or certificate is a better word for it, both for travel and for accepting international visitors. New York State in the United States also issued a passport that was broader in its scope. So here's another divide. Some governments are actually mandating or coming close to mandating vaccines for people in various circumstances. The president of the United States is opposed to it. And the World Health Organization has declined to issue a I don't know, I guess a recommendation that there be vaccine passports, literal passports for entering different countries because of the inequities that that would bring about. So this is yet another aspect of a situation where some people are urging an activity that others are opposed to, partly on the grounds of liberty, that is independence and liberty and privacy, and others are favoring because it has at least the possibility of reducing, not eliminating, but reducing the impact of the vaccine.
I'd like to, at this point, pick up on a comment that's been made in the chat concerning, Laurie, your kind of encapsulation of this radical ethics of care and empathy. And we have a questioner asking how we might extrapolate from COVID to other risks and activities with similar mortality rates, and should they be tackled with the same vigor? And I mean, this touches on a question, and again, maybe I'm just desperately seeking some silver linings here about whether this new awareness of the imbrication of individual choices in collective risk might spill over to provide a fresh ethical incentive to consider forms of risk that we have up to this point considered tolerable, and now, given the energy that we've given to constrain COVID, should arguably be considered intolerable. Are there any sort of new domains where this ethics you describe could be applied to good effect, or that you even see being applied or experimented with?
You know, I study malaria and the ethics of our response to malaria, which is just talk about pessimistic. You know, the world has continually accepted an extraordinary level of death, a level of death that I used to think was unacceptably high, which is that someone, usually a child of color, dies every 2 minutes. In fact, will have died during our conversation cheerfully. Will be dying over and over of malaria, completely preventable occurrence. And I feel discouraged that we've as a field, as a country, as a world, accepted that level of death of children. And so we've actually proven that point already. We're apparently just fine with the death of children in the developing world. Not our children, the children of the developing world. And I think the story of this would be, Richard could tell us more about this, is cholera. Like cholera was a big crisis, emerged suddenly a big crisis, but as soon as it was clear it only affected the poor, in a certain period, cities were reconfigured so the cholera wasn't a threat to the wealthy. As soon as it wasn't a threat to the wealthy, it settled back down into now we have endemic cholera. We have cholera outbreaks every now and then, but as long as they don't touch us, then everyone feels that we can live with this. And that's a moral failing. That's one of humanity's many tragic fails. And I had hoped initially that this would awaken in us a different sort of response. In the city of Chicago, we meet together as bioethicists across the city, and we pointed out rapidly that the vaccination was weighted to the wealthy, because that's where the pharmacies were in the city. And the mayor took that in, and people had enough clout to get that attended to, and there was an incredibly aggressive attempt to change that. And then it faltered, and then people couldn't be convinced. And then all of the many years of suspicion about the state and about state action began to really take a toll, and the very communities that had been targeted, especially by the mayor, began to resist. And so this is a hard problem, and in part I'm curious and interested in the role of ethics in that story. I grew up in a time when we thought mistrusting the state was a good idea. We should be suspicious of state action, that citizens should take things into their own hands. Our field foregrounded autonomy as a way to resist and question physicians. After saying that for many years, like, surprise, surprise, people actually believed us. So now I think we have to really rethink our part in thinking about liberty as an ideology, and what we need to do to change that. It's not an ethics of care for me, of course. It's Levinas, as opposed to an ethics of care. This notion of the ontological need to understand the self as constituted by the act of attention to the other. But it would mean changing a pattern that, as Bertrand and others could tell us, has been entrenched certainly throughout the 19th century. that the way to deal with epidemic disease was to isolate. The other was to remove oneself from the danger by creating cities, states, water systems that took the disease away, and so we didn't have to cope with it. I live in a city that rerouted the river so that we wouldn't get cholera, and people in St. Louis would. So this is a long-standing, deeply entrenched, architecturally defined in our city choice.
Does anyone want to jump in here in response to Laurie's reply?
Well, I'm interested in the question of how you, I'm going to sound like I'm trying to create a liberal counterpart to Fox News, but how do you build an apparatus of messaging to push back against narcissistic, autonomy principles? How do you build an idea of trust in government when lots of governments can't be trusted? I mean, the models are so varied around the world for governments I don't want to be part of. How do you create a public health sector that is itself pure and trustworthy? The priests of public health can be trusted. We don't even trust priests anymore. So, but it's an interesting question. I think of this as a lawyer. Lawyers are often salesmen. They're advocates. They're selling ideas. They're selling a client's innocence or a client's suffering in a civil case. How do you message this? How do you work out building up the framework to get at Laurie's observations, which are terribly depressing?
I think, sorry, I didn't mean to interrupt there, Barry.
That's it.
I just to pick up on something you've said though, and I think there's a slippage here that's maybe worth attending to, which is the relationship between autonomy and narcissism, or autonomy and egoism. And I mean, I think that one of the challenges in public health messaging is that a lot of the measures throughout the pandemic have leaned on this, rightly so, an attention to other directed action, the consequences of your actions on others. But on the other hand, ethically speaking, it is morally defensible to, for oneself, want to live a good life. I mean, this is the foundations, arguably the foundations of some of the foundational questions of philosophy. So you owe ethical obligations to others. There are, however, at the same time, ethical obligations you owe to oneself. And maybe it's the presumption that autonomy is the same as independence or selfishness that is the problem here. And instead, we need to move towards some sort of ethics that does protect individual autonomy, but sees that autonomy as emerging from a network of relationships or our interdependence with others. And maybe there needs to be I think some of the weariness among admittedly privileged populations perhaps comes from the fact that there hasn't been a kind of recognition of that ethical duty that each person has also to live a good and meaningful life for themselves, which can be very difficult under conditions of social isolation and distancing and so forth. So I'm not sure if that adds to the picture or perhaps muddies it.
Let me just add a little footnote to that, because I think you make a good point. There have been a series of feminist handbooks of the law produced by Cambridge University Press. And there was a feminist handbook on death and dying, which involved rewriting famous legal decisions and rethinking. And I rewrote the Bovia case, which was all about autonomy and didn't take into account this context of disability and other issues that feminist theory sees as very central and important, expanding this central single isolated figure into a larger sense of possible networks and so on. So I think you make a great point. There are little steps happening, I think, in some of the writings that are going on.
Ruth, you want to jump in here?
Just a very brief point, and that is to add to what Barry just said. The concept of relational autonomy has been introduced, and that is largely, actually on Barry's point, from the feminist literature. So people are thinking about it and talking about it, but these are bioethicists talking to one another. I don't think, if you'll excuse me, about South Dakota, that they're actually reading feminist writings in
No.
South Dakota, but they're not reading them in New York and Pittsburgh either. So, but I mean, it's just worth saying that at least in a philosophical or bioethical context, that the concept and the applications of autonomy have been broadened.
I mean, to pick up on sort of tying together several strands of this discussion, I mean, it does seem to me that that what we're talking about here is kind of expanding the circle of the we. And in the context of COVID, the moral call is to say those suffering in Latin America, those suffering in India, they are us. I mean, this is not the end of the pandemic. The pandemic is continuing, but it just seems like that nettle is not being grasped. And we've got an interesting question here from the chat, which is, as someone from the global south and the developing world, if it continues to appear that the global north and the developed world doesn't care about us, what can we as the global south do for ourselves? So do any of the panelists have a response to that question?
I'd like to hear from the person who raised the question from the global south, because that's what the answer has to come. The global north has not done well in making these plans, right, historically.
No, that's true. We shouldn't ventriloquize. Bertrand, you want to come in there?
Well, I guess we cannot hear it. But I think it's very. I mean, does the global north not care about the global south? I think it, in a funny kind of way, it does. It does, and it will. But mostly by giving an epidemiological meaning to restrictive policies on migration, and by reshaping what were already exclusionary practices and border tightening practices, and investing those with a biomedical legitimacy that it hasn't had for a very long time, but has had in the past. So this is where the future does echo a lot of elements of the past, not necessarily in the same order, in the same rationale, but it's very striking that biomedical justification and legitimacy to exclusionary practices and filters or border control are actually extremely popular, and actually have a sort of how to put it, commonplace legitimacy, which I think is going to be quite difficult to fight off. And I think so. That's one aside. But it's interesting that when the epidemic started, it did look for a while that in many African countries people had managed the epidemic rather better than the north. And I had colleagues in MSF who actually reported back that people who had been living through Ebola basically were not shrugging it, but were basically saying we've been coping with Ebola and we can cope with this. We have a sort of frame of reference to handle epidemic behavior in an epidemic. I'm not sure that I think this may have been a misconstrued perception, that it may have been linked to the fact that the prevalence was rather lower at that earlier stage, but it does beg some interesting questions that some countries are living permanently with the kind of casualties that Laurie was pointing out in relation to other diseases, and actually have mechanisms, very often very local mechanisms to deal with epidemic outbreaks, which are very socially and communally managed. But you cannot generalize. It's a picture of many different approaches.
I mean, so this is becoming an increasingly bleak picture you're sketching out in terms of. I'm
a pessimist at heart.
Really, but what I hear from you is. Oh, sorry, Laurie, go ahead.
I was saying maybe all bioethicists are pessimists. Maybe that's part of the story, right?
But I mean, what I hear from you, Bertrand, is a scenario where essentially restrictive immigration policies are imbued with a degree of legitimacy and thereby secure greater support even amongst sections of the population who might otherwise have been inclined to be skeptical of them by virtue of the pandemic. And so this could lead to a kind of further entrenchment of national borders and inequalities. And indeed, something I did want to pick up, even though I'm conscious we're getting to the end of the hour, is this question of nationalism. I mean, it's kind of remarkable to think that 10 years ago, there was all this, the talk of globalization, the end of the nation state. And, then there was Brexit in 2016 and Trump, and now we have COVID. And all of a sudden, the question of the nation state and specific national regimes has had a huge impact. And so I thought perhaps we could discuss the question of nationalism, both in terms of the extent to which different nationalisms have shaped responses to the pandemic, and then the path dependencies of how that affects the question of how the pandemic shifts. I'm now becoming reluctant to use the phrase ending the pandemic. Yes. But yes, just the question. That
I mean, we had a comical version in the United Kingdom when the Scottish leader actually basically invited Scots not to visit Manchester or Blackburn and the Greater Manchester area as a kind of a plague pit of the Delta variant, and actually tried to claim that she could even prevent people from Greater Manchester from traveling to Scotland. So inventing borders that actually haven't existed for 300 years, and with the notion that somehow a kilted police might actually arrest people with the wrong address on. We're in fantasy land, of course, but it's interesting that this kind of discursive formation might have emerged in relation to the pandemic, of course, in a broader debate about Scottish nationalism and the potential breakup of the United Kingdom.
Did anyone else want to jump in here with any thoughts about the role of nationalism in responses to the pandemic? I mean, I think there's an interesting question that's been raised in the chat about the extent to which, again, talking about the distinction between the global north and the global south, the extent to which countries in the global north care about what's happening in the global south for genuinely compassionate, humane reasons, and to what extent there's an instrumental logic there about caring what happens in the global south because it has spillover effects. And then there's a second question as to what extent does that distinction matter? If it gets rich countries to care about what's happening in other parts of the world, then maybe that can nonetheless be a moral bridge to some broader sense of global community. Yes, I guess I'm curious to hear from the panel about the extent to which they feel that the rationale behind that distinction matters.
Can I just point out that somebody made there are some people who are more optimistic than us in the chat room, so I think we ought to recognize that.
Right.
One of whom pointed out, Laurie, that malaria. There have been some progress in treatment of malaria, and somebody else pointed out that there was this fantastic surge of science for COVID. But the interesting thing is, of course, how nationalized or how national labels were applied to this international science, and how it's been misrepresented. As notably in the United Kingdom, they're famously a product of greed, wasn't it? The speech. We had a prime minister who argued that the vaccine was a product of human greed, so almost like a spoof of a film from the 1980s. But this notion that private money and national identity were going to shape the response. So, I mean, you responded, Laurie, quite strongly that malaria has been underfunded. I think that's the general point, isn't it?
And in general, people work very hard to try to do things. The vaccine efforts have so far not been effective. They're only 40% effective. They require several doses in resource-poor countries. If you bring a kid back and forth for 40% chance, they're not effective in everyone. And it's very hard to end a parasitic disease with a vaccine. It's a different mechanism. Yes, there's new efforts. People are trying really hard. I follow their efforts. There's thousands and thousands of great ideas, but has historically been underfunded and is not. It's better. it's not 1 million children a year anymore. It's only 500,000, but it still is an unacceptable level of death, and it could be done better. Bed nets. Talk to me offline about why bed nets are problematic. And why, while wonderful, they have their limits. So it stands for me as an example of how difficult these problems are and how much money and resources we would have to use to really fix it. The interesting metaphor of this is the Panama Canal. After the French failed to build the Panama Canal due to the catastrophic losses because of malaria and yellow fever, the American companies came in and they created a 5-mile zone on either side, plowing through the jungle that's malarial and yellow fever free, and then beyond it was whatever happened, right? They didn't care, they didn't see it. And then that 5-mile zone on either side became the safe zone, which was, for me, a very interesting metaphor for how the global north and how modernity was able to address these 19th century challenges. It's no longer an acceptable way to run the world, and we've seen how it failed. And as we were all huddled in our little houses, we really, I think, viscerally could understand the limits of some of the stories we've been telling and writing about for the years. The mistrust of pharmaceutical companies, the privacy of autonomy, as I said before, the way that we can go ahead with our, cool applications of science and concerns about them while ignoring, tragic losses of disease in other parts of the world. All of the constructs of bioethics really they need to be examined as well. In addition to our understanding for how politicians ran this epidemic, we need to really reflect on our own practices too.
Well, I think it feels to me, go back to the earlier notes about questions of temporality. There's certainly a sense in this conversation that there's a certain sense of return and entrenchment for some of the existing problems and inequalities that COVID has exacerbated. Perhaps to just end the discussion, does anyone see any bright spots on the horizon, any green shoots, anything generative that emerges from this generationally extraordinary event?
I think a greater degree of literacy in epidemiological data is actually a small bright spot, but marginal gain, I would say. Certainly everybody's an epidemiologist now. I mean, this is one of the striking features of every conversation you have. So yes, that's my little bit, and I think if people pay attention and get interested, then perhaps they'll have a wider reference frame to engage with.
I mean,
Ruth,
cool.
Sorry, Laurie, go ahead.
That's very cool that mRNA vaccines work. That's we all of us here happily today because in fact that extraordinary miraculous save by science. We don't know how it plays out at the end, but at least for this first 6 months of it, widespread vaccination has been extraordinary. The thing I think is the brightest note of this, actually, New York celebrated it yesterday, is whenever I wrote in the past, as many of us here, I know Ruth has written too, about ethical issues and epidemics, one of the problems was we were thinking about the AIDS epidemic where healthcare workers refused and turned away from sick patients. And that did not happen. In their millions around the world, doctors and nurses and janitors and food servers raced forward, returned over and over into those hospitals in every country in the world, including places like Brazil and Italy, where they were death traps, and did not shrink and did not falter. And that is, for me, the most extraordinary lesson of this entire period is the raw courage and nobility of facing death, which big philosophers would be very proud of them, and I'm very proud of them too. And I think that's one of the privileges of being a bioethicist, is to be adjacent to that extraordinary moral gesture, and that almost should be enough for us.
That's a very fitting testament. Ruth, did you want to jump in there?
Just one more thing, and that is, I think it's brought more awareness. I mean, the news focuses on things like what happened in India with huge numbers of people succumbing to the Delta variant. and other news where the United States, at least, has been a very insular country with people only looking at news and news broadcasts and things without much awareness or interest in the rest of the world. So I think the fact that this is a global pandemic and that's what's happening all over the world, and even the attention to the scientific aspects and the current ongoing beginnings of a debate about the origins of COVID in China, is probably making greater segments of the population a little less nationalistic, or at least a little less. They may be grateful that they live in the United States, but still, I think there's more awareness of global activities and some of the horrors that have been visited on other countries, poor countries.
Barry, would you like to make any concluding remarks?
Well, I think I just was going to follow up on Ruth's comment about when you talk about modeling public health measures. You know, we watched India's disaster in motion, and we could see it was a disaster in development. But you look at Taiwan, trained by previous epidemics to respond very swiftly to the evidence from China of a virus afloat. We have a lot of models, and I think if you look at the global picture, models are always useful. And I think the other thing we forget with looking at, for example, Africa, we forget there are a lot of bright spots and there's a lot of talent in Africa. And there also is a market for things like tools to fight malaria. There's not really a market in underdeveloped countries to build a whole vaccine generating facility. But there are markets for products that protect tents, protect walls of buildings. There are ways to reduce the effect of mosquitoes other than genetically re-engineering them, which is the way we think. Sometimes I think Western science thinks a certain way, and down there in the trenches of these countries, there are entrepreneurs thinking, I bet I could sell for pennies a solution to help this village do much better with mosquitoes. And that's maybe pie in the sky, Laurie would say.
Right.
I looked at the Sardinian,
Right.
I looked at the Sardinian experience right after World War II, and the massive use of DDT, for example, which was viewed as a success story back in those days. So I think there are other possible blossomings that might give us a little opening for optimism, maybe.
Well, look, I think that's a very good note to end on. And I mean, I think we've obviously covered a huge amount of ground today, both historically and philosophically. And as is always the case, there's not a kind of simple picture to emerge. And it's a question of new trenches being dug, old grievances being cemented, but on the other hand, new possibilities opening up before us. So we can only hope that we will rise to the occasion and be able to embrace those possibilities. So I'll just take this opportunity to thank you all for such a rich and interesting discussion, and also to thank the observers for the very, very helpful comments in the chat, which were very fruitful in helping us calibrate the conversation. So I hope to have a chance to see you all again at some point, and thank you very much for your participation. It's been a real pleasure.
Sally. Thank you.
Thank you, Sally. It was a great sharing. Thank you so much.
Oh, thank you so much. It was really my delight.
Yeah.
Thanks, everyone. Take care.
Okay.
Bye-bye.
Thanks for sharing.
Bye.